nodes or IVC is stage 3. If it is limited by the renal capsule inside the kidney, stage 1. If it goes beyond the capsule but still limited by the fascia, stage 2. Easy?
Doctor, can you repeat?
It's coming. Just follow me. Okay, so this is a tumor again. I'm showing you it's a cystic cum solid. Some part is necrotic. That's why it looks cystic. But actually it is solid enhancing tumor. And if you do a pyelogram, you see there's distortion of the collecting system. This is a renal cell carcinoma, which is extending outside up to the Gerota's fascia. So what we are trying to stage is, we are trying to look for lymph nodes. So in this case, there are these lymph nodes here. So once it goes into the lymph node, it is stage 3. Okay. Now, what else do we look for? We are also looking for any distortion of the collecting system here. Again, another renal cell carcinoma. But this one has, again, lymph nodes. You can, again, see some lymph nodes here in the para-aortic region. Again, stage 3. Another renal cell carcinoma. Okay. So what you're looking for renal vein invasion, perinephric invasion. You're looking for lymph node or adrenal metastasis that is just lying adjacent to it. Because the staging depends on where it is extending. Now this one is going into the renal vein and IVC. So this is stage 3. Lymph node and IVC, 3. This one again, renal vein and IVC, stage 3. This one has gone to the liver, so it has crossed the renal fascia. It has gone to the adrenal on the other side. It has gone into the other kidney as well, stage 4. Okay, so now if I was to show you another one, this is stage 1, still limited by the capsule, hasn't gone into the perinephric fat. Another one here. So these can be excised. So if it is limited in the stage 1, you can have partial nephrectomy. So you can sort of treat the patient with partial nephrectomy. Now this is very easy if you just try to memorize this. If you look at this image, 7 centimeter within the kidney, limited by the capsule, renal capsule, it is stage 1. So these can be excised depending on which part it is. So if it's in the lower part, you can excise it from here, so you can leave the upper part of the kidney. If it is going beyond the capsule, okay, but still it's not reached the perinephric fascia, it's still limited by the Gerota's fascia, it's stage 2. If it goes into IVC and the lymph nodes, stage 3. If it goes beyond the Gerota's fascia, into the adjacent liver, adrenal, kidney, any other structure, lymph nodes, IVC, it all stage 4. Okay? So anything going beyond the Gerota's fascia into the adjacent organs or metastasis elsewhere is stage 4. Clear on this? I guess now it is very clear.
Doctor, lymph nodes other than the para-aortic lymph nodes is stage 4?
Any lymph node is stage 3. Obviously, when you have stage 4, you are supposed to see lymph nodes as well. Understand? Stage 4 is above stage 3. But if it is just lymph nodes, it's stage 3. Okay, so this is which stage? 1. So it's just still in the kidney, in the capsule. Which one is this? 2. It's around it's gone beyond the capsule, but still in the perinephric fat. Hasn't gone beyond the Gerota's fascia, stage 2. Stage? Very large lymph nodes in the para-aortic region, lymph node, necrotic area, gone beyond the capsule. So stage 3. Whenever you have lymph nodes, it's going to be stage 3 or 4. Stage 4, liver, beyond the Gerota's fascia. And obviously, lymph nodes would be there. When you have stage 4, obviously it has gone beyond the stage 3. Okay, so cystic renal cell carcinoma, these are 2 different patients. This is another entity. But again, remember, there would be a solid component inside. Okay. Another example of, what is this? Which Bosniak? 4. So obviously this is a tumor. When you have enhancement inside a cyst, irregular wall, or an irregular septa, it's going to be malignant. So the tumor most common in children is Wilms tumor. You have to differentiate it from the other tumor, which is the other commonest one in children. Any adrenal tumor?
We still didn't discuss
Neuroblastoma. Okay, so you have to differentiate it from neuroblastoma. So Wilms tumor is coming from the kidney, neuroblastoma is coming from the adrenal. So if it is coming from the adrenal, it will displace the kidney. So you would see kidney lying somewhere, either in the pelvis, or it would be displaced up, or in the laterally, because adrenal is going to push, when the adrenal tumor is going to get big in size, it will displace the kidney. If it is coming from the kidney, you will see some part of the kidney attached to the tumor. So it will be called as a claw sign. So some part of the kidney would be attached to the big tumor. So if you look into this is the big tumor on the right side, and this is the kidney which is stretched around it. So this is actually the claw sign. Okay, so to differentiate it from neuroblastoma, look for the kidney around it. If you see some tissue of kidney stretched out around the tumor, it is Wilms. If you see the whole kidney displaced somewhere, it is neuroblastoma. Clear on this? Let's see more examples. This is another child. Usually it presents below than 3.5 years of age, and they have metastasized before even you diagnose it. In around 10%, 5 to 10%, you can have it bilateral. So you can read all these details about this. But here you have an X-ray where there's a soft tissue mass. It is displacing the bowel. Once you do an ultrasound, you see a solid heterogeneous mass here. Again, heterogeneous enhancement. And you see some tissue around it, the renal tissue around it, stretched around it. So this is a Wilms tumor. Let me show you another example, some renal tissue around it. So it's a claw sign. So you see some renal tissue around the tumor. So it is a Wilms tumor. If you see the whole kidney displaced somewhere, not just the little part of the kidney, then it means it's an adrenal tumor. Okay? So remember to look for the claw sign when you are trying to differentiate between renal Wilms tumor and neuroblastoma.
Doctor, can you please point out the claw sign?
This is the one.
This is the kidney.
This is the kidney. This kidney is sort of, it is as if the tumor is attached to this part of the kidney.
Okay. And where's the other kidney?
The other kidney is this one.
Oh, okay.
And this is the contrast in the collecting system. This is the contrast in this collecting system, and this is the cortex that is stretched around the tumor. So this tells you that this has arisen from the kidney. It's not that it is pushing the kidney to one side. Okay, so if you see bilateral renal masses, like you see here, one here, one here, one in the spleen, another one bilateral masses, you have these large lymph nodes, okay, lymph nodes, then you should also think of lymphoma. Lymphoma can also affect both kidneys and can have bilateral renal masses. So these are usually immunocompromised patients. You would have splenomegaly, or you can have lesions in the liver and spleen, because this all lymphoproliferative tissue can be affected. Another example where you have lesions in the liver, in the spleen, and in the kidney. Another lymph nodes. These are all lymph nodes. The kidney lesions, multiple in both kidneys. Again, both kidneys, lymph nodes. So you have to put them all together. So if you see bilateral masses and you have these lymph nodes and spleen lesions, think of lymphoma. Then don't think of renal cell. Again, another example of lymph nodes, very large lymph nodes, necrotic lymph nodes, so lymphoma. Another example, kidney, left kidney and right kidney both have masses. So another example of lymphoma in an AIDS patient. Now you can also have some tumors which are benign, like this containing fat. This one again has fat. This is small angiomyolipoma. This is a large angiomyolipoma. Angiomyolipoma. Angio means vascular, myo means muscle, lipoma means fat. So you have all these three components. Now the problem with these angiomyolipomas is their angiomatous part is sometimes leaky. So these can develop hemorrhages. So if the tumors are large in size, these patients are prone to develop hemorrhages. So you have to be careful with that. If you have bilateral fatty lesions like this, don't mix them up with polycystic kidney disease. The cystic disease are very well rounded cysts. These are not like cysts. If you measure them, these are fat containing lesions. So if you have them bilateral, These are multiple angiomyolipomas, and usually these are seen in tuberous sclerosis, in patients with tuberous sclerosis. If you don't know, go and read about it. This is echogenic lesion on ultrasound because these are fat-containing lesions. Okay.
Doctor, can you go back to the previous slide?
You want me to go back to this?
Yes. How would you differentiate that this is lipid?
This is fat. Okay. If you look at this is the mesenteric fat. Okay. This is not the air. If you measure the Hounsfield unit, it would be very much similar to the fat. You see, this is the subcutaneous fat here. Okay.
Yeah, how would you say that this is lipid, not necrotic tissue?
This is lipid and
Not necrotic tissue.
because this is all fat. This is all fat. Necrotic tissue. Okay. If you measure the Hounsfield unit, the fat would appear minus, like minus 40, minus 50. If you have a necrosis, that would never go to the -1. If you have necrosis, there will be around 1, 2, 3, 10. You know, the Hounsfield units will be around 1 or 0, near water. If you have fat, it will be into the negative part. Okay, understand? Try to understand this. Like the xanthomas have lipid-laden fat. So if you measure them, they'll be again negative, minus Hounsfield units. So the CT can tell you that. If you measure the area, okay, what is this density? It will tell you, okay, if it is in negative, that means fat. If it is positive, it's not going to be fat. Understand? Anything minus is going to be fat. So if I measure the Hounsfield unit here, it will be minus something. If I measure it here, it will be minus something. Okay? That will give me a clue. But since I know this, I see this every day, so obviously for you it is going to be, for beginners, it is better to measure. But I know this because I see them every day. Okay? Okay, so another angiomyolipoma, I told you they have tendency to bleed because these are abnormal vessels, angiomatous vessels. These are abnormal vessels. So, you know, they can bleed anytime. This one has bled. So perinephric, you see this is, again the blood is limited by the fascia. I told you the disease process is limited by the perinephric fascia. So you see that the blood is limited here in the retroperitoneum. But you can make out the fat here. You can make out the fat here. If you measure, it will be negative. You can make out the fat here. Okay? Okay, so what is the difference? Anyone? What is disease? This is angiomyolipomas? Okay, first tell me which one is CT and which one is MR.
This is MRI.
This one is?
CT.
And this one is? Okay, good. Now tell me, are these fat?
Yes. No.
Are these fat? Or are these cis? Cis. Why they are cis? They are well defined. They are rounded. Unlike the angiomyolipomas, where there was zigzag, these are well defined, rounded. You can make their boundaries, okay? So these are cis. Now tell me, this kidney has cis, this kidney has cis, this liver also has cis. So, polycystic kidney disease, do they have liver cis? Yes, they can have cis in the liver, they can have cis in the pancreas. So this is a polycystic kidney disease. What about this one? This is just the cis in the kidneys, but doesn't have it in the liver and the... So if I tell you this patient had renal failure, then which type of... Acquired polycystic kidney disease. Okay, got an idea now? This one is the autosomal dominant one where you have liver cysts as well. This one doesn't have liver cysts because the cysts are only in the kidneys. The kidneys themselves do not look nice. Okay, and these cysts developing after renal failure. So this one is acquired variety of polycystic kidney disease. Good. Okay, so we are left with the transitional cell carcinoma, which is a urothelial cell tumor. So this lies in the collecting system. It can be in the renal pelvis, ureter, or in the urinary bladder. So we need an IVP. Okay. If you do a CT scan, you would see a filling defect in the collecting system like this. If you do an IVP, you would see again another filling defect in the upper calyces like this. You would see a filling defect in the renal pelvis and the renal, collecting system. Another filling defect. So these are all transitional cell carcinomas. In the renal pelvis, again, another filling defect. Okay. Remember, these are poorly enhancing tumors, and they are known to have multiple deposits. So it can be in the upper part, it can be in the bladder, it can be in the other kidney. It's not that usually there is one tumor. You have to look for the rest of the collecting system. Okay, so sometimes they are small like this, then they can be mixed up with polyp and blood clots. So if there's blood clot or a polyp, they can also give you a filling defect inside. Okay, so you have to be careful. Okay, so we are left with the last thing, which is trauma. So if a patient comes with trauma, what to do with these patients? Okay, I give you a scenario where a patient lands up in the ER, he has a road traffic accident, he has injury to the abdominal cavity, he is vitally stable. What would you do with him? He's vitally stable. So what imaging modality would you ask for? You're working there as a house officer.
Ultrasound.
Okay, ultrasound. It's a good option.
X-ray.
He's vitally stable, yes. CT. CT is also a good option. So which one would you have, ultrasound or a CT?
Ultrasound. Ultrasound.
Okay, so we have ultrasound which is called as fast ultrasound. Have you heard of this? In the ER setting, they ask for a fast ultrasound. The reason being, what you do is you go in and you just check for any free fluid in the peritoneal cavity. You look at the viscera quickly, and because you don't take time to do a whole scan. All you're looking for is free fluid in the peritoneal cavity. Now, when it comes to renal injury, it's not that only the artery or vein is going to be injured. At times, the collecting system can also be injured. So there would be extravasation of urine inside the peritoneal cavity. So if you see extravasation of fluid, then you'll be able to pick it up on fast ultrasound. And then you would ask him, okay, this patient although this is vitally stable, but he has free fluid inside. So this fluid can be coming from a lacerated ureter or pelvis or any other place, like it can be any other visceral injury. So then you will ask him, okay, this patient needs a CT scan. Okay, so you start off with a fast ultrasound, and if that is negative, you don't see free fluid, then obviously you don't need to do anything. If that is positive, then you would ask for a CT scan. Now, if the scenario is the patient comes vitally unstable, okay, he has an abdominal injury, you suspect renal trauma, and he's vitally unstable, what would you do with him? Why CT?
MRI.
Faster. Yes, it's faster, not MRI.
Yes.
You don't ask for an MRI.
Because
In an vitally unstable. We don't want to have these patients in MR. So even we don't want to have them in CT. If he's vitally unstable, why would you want a patient with 60/30 blood pressure in a CT?
you treat.
You want them to die there on the scanner? Being radiologists, we don't want to touch any patient with such vitals. So what do you think we would do? We will tell him keep it and take him into OR. We don't want him. If the patient is vitally unstable, you suspect renal trauma, you should not do a CT scan. You don't send him to the ER. You don't send him to the radiology. You take him to OR. You have to operate. You have to operate and find which vessel is torn. You don't have time to investigate. Because time is vital in these patients. If you are trying to investigate, you send the patient to radiology, it will take 5-10 minutes to come, 5-10 minutes to go, 5-10 minutes to start the study, complete the study, then to report 5-10 minutes, 30 minutes gone, the patient would die. So we don't want that to happen. And we don't like these patients in our radiology department. We like nice, clean patients, You come on foot and go back. So we do a fast ultrasound in cases where we suspect extravasation of urine, injury to the collecting system. But if the vitally unstable, they have this vascular injury, you just send them immediately, you don't do investigations, you just send them to the OR. Okay? So this is a shattered kidney. By the way, I don't know why this patient had a CT. Maybe they're suspecting something else. But you won't have. You should not be doing scanning on such patients. Yes.
Didn't that would take time if you didn't know what's going on and then you open and try to find out?
No. They know what they have to do. Surgeons know they laparoscopically or they have to open it because every minute is important. You cannot waste time in the radiology. Understand? What will we do with him if he is already 60-30 BP? How would we treat him if he collapses there? You understand? They are more likely to save the patient rather than sending them their patients to us. You understand? Even we don't want children crying in our department. If the children are crying, we tell them, okay, make them sedate them, then send them back. So we need to have clean, nice patients, quiet patients. Okay. So what about this now? What's wrong with this kidney? It's either infarction or striated nephrogram. This is a pyelonephritis case. Triangular. Remember the one that I showed you? So it's a pyelonephritis case. Don't think this is a trauma case. Remember, the trauma case would be something like this. There would be a laceration going into the cortex, and there would be hemorrhage around it. So the first three conditions where you have subcapsular hematoma, laceration 1 centimeter, or a laceration more than 1 centimeter, these are all, you don't do anything. In the first 3 grades, you don't do anything. Safe patients. You just observe them. But if you have a shattered kidney like this, grade 5, or you have a kidney where there's extravasation of urine, or there is an injury to the minor vessel but he's vitally stable, then you need to monitor them. Okay? So these one are the controversial ones. These one are doing nothing with the patient. Okay? Just admit them and observe. So remember, grade 1, contusion subcapsular hematoma, grade 2, laceration 1 centimeter, grade 3, laceration greater than 1 centimeter, but no extravasation. Grade 4, there is extravasation of urine, but not that much renal vascular injury. But grade 5 is a shattered kidney with devascularized, or there is no blood supply compromise. Then you need to sort of operate these patients. You have to clamp that artery that is bleeding. Okay, so this is a case of grade 4, which is grade 5, which is a shattered kidney. Okay. Yes.
Can you go back to the pictures?
This one?
The picture above, I thought pyelonephritis is
This
more,
one?
I thought pyelonephritis is a more
This is pyelonephritis. Why? Because this part is not enhancing, but there is no defect inside the cortex. Okay? There is for a cortex to have a defect like this. Sorry, I couldn't. I thought I put a picture with this, but obviously it's not there. But remember, this cortex, there would be a sort of breach in the cortex. Okay? It's not be that that part would not enhance. There'll be no cortex there. If there is trauma, laceration, you will not see any cortex there. Understand? Like, let me show you this one. You see, there is no cortex here. There's no cortex here. There's no cortex here. Okay? So you will have a defect in the cortex.
Yeah, but my question is why it is pyelonephritis but not infarction?
Pyelonephritis is going to lead to infarction. It's the same thing. Okay, so blunt trauma, renal trauma, grade 1, 2, 3, I've told you, you do nothing. Grade 4, 5 R management is controversial, depends on the hemodynamic status, as I've told you. If he's hemodynamically stable, you ask for a fast scan to rule out any extravasation of urine. The degree of urinary extravasation, renal bleeding and associated injuries all depend. It's not that only the renal, it can be splenic injury, it can be liver injury, it can be a pancreatic injury associated with a renal injury, so you have to take all into context. Okay, so do a fast ultrasound, no free fluid. Okay, if there is fast fluid, shift him to OR. If he's stable with no free fluid, if he's stable with no free fluid, then send your clean patients to us. Okay, clear on this?
Yes.
If the patient is stable, no free fluid, but you still suspect renal injury, then send us your patient. Otherwise, don't bother. Okay, urinary bladder lesions. Remember, you can have transitional cell carcinoma like this. You can have calcifications in schistosomiasis. You can have large tumors like this. You can have also calcifications with the tumors. Few more conditions like prostate obviously is also included in the genitourinary system. Remember, this is the peripheral part and this is the central part. For prostate evaluation, we have multi-parametric MR imaging in which we make use of diffusion weighted image, post-contrast images, and T2 weighted images. So these three are used. But remember, usually the lesion is going to be lying in the peripheral part of the gland. If the transitional part or the transitional part has enlargement, this is known as BPH. So this example is of BPH. This one is a tumor in the peripheral part, so this is a prostate cancer, whereas this one is BPH. The enlargement is just because of hypertrophy of the transitional zone. Okay, another thing, testicular evaluation also comes. On the male side, you have epididymis and the testes. So if the patient, child or adult presents with swollen, tender testes, then obviously you do an ultrasound and you see if there is increased vasculature or increased vascularity inside the testes or the epididymis, because then it means epidydmo-orchitis. You have to differentiate it from testicular torsion. In children, testicular torsion is very common. So if torsion is there, then you would not see the blood supply inside the testes, unlike this. So if there is increased vascularity, it's epidydmo-orchitis. If there's no vascularity, it's torsion. If it is normal vascularity, then it is nothing. Okay? Clear on this?
Yeah.
So this is another example of increased vascularity in the epididymis, and then there is this hydrocele that is associated with this epidydmo-orchitis. So epidydmo means epididymal inflammation, orchitis means the testicular inflammation. If you don't treat them, then the patient would come back again with an abscess developing inside the testes. How would you know this is a testicular abscess, not a tumor? By again putting a colored Doppler. If there is a tumor, they would have blood supply inside, going inside the tumor. If it is an abscess, you will not have blood supply going to the necrotic part, which is the necrotic caseating part. So the abscess, obviously, you would have only blood supply in the wall of the abscess, not inside where the debris is. So this is how you would differentiate, and obviously clinical presentation would also be different. Inflammatory markers would be raised in cases of testicular abscess. Okay, thank you very much. Probably we finished 5 minutes late. We should have finished earlier. Anyhow, if you have any questions, the email is there. I know you cannot become an expert in just 1 or 2 lectures. So